So if we go back to our case, remember we had our 63-year-old white female with stage 3 CKD, so it's about the time that many patients with CKD will develop anemia. Her hemoglobin has dropped to 10.3. Her TSAT's 26%, and ferritin is 230. So based on the information that we've gone over, so thinking about our KDIGO recommendations that recommend starting an ESA when hemoglobin is less than 10. So her hemoglobin is 10.3. So according to our guidelines, she does not qualify for an ESA. So we wouldn't initiate darbepoetin. But then thinking about to our KDIGO iron recommendations, her TSAT is less than 30 and ferritin is less than 500. So she's a great patient to qualify for iron. So again, her iron levels meet that point, and also her hemoglobin. So she does have anemia because her hemoglobin is less than 12. So she would be a patient that would need iron. And so hopefully by giving her iron, we can get her hemoglobin up and potentially delay the need for ESA therapy. So how do we treat? What do we give them? There are 2 dosage forms available. We have oral iron and IV iron. There are several different iron salts to give oral iron. The most common we see is ferrous sulfate. It's given 3 times a day. There are several other options as well. The most common adverse effect you see with oral iron is constipation. There is no difference between the different iron salts in terms of how much constipation it causes. The treatment recommendation is to get up to 200 milligrams of elemental iron a day. So if you get up to 200 milligrams of elemental iron a day, you're going to get equivalent response or equivalent adverse effects in terms of constipation. So there really isn't one salt that's better than the other. Cost might be something you would consider. How many times a day a patient has to take the medication would be something to consider. So there are also the different dosage forms available. They're all available as tablets. There are some available as elixirs, so that might be another consideration for patients that can't swallow or would prefer a liquid option. So IV iron is the other option to use, and there are 5 different products that are available. And they differ significantly based on how much is given at a certain time. So the recommendations for treating iron deficiency anemia in patients with CKD with IV iron is to get up to 1 gram total for the dose of treatment. However, with these different products, you can't give 1 gram all at once. The only exception to that is iron dextran. Iron dextran you can give 1 gram at once. However, the infusion has to be very, very long, up to 4 hours to prevent any type of infusion reaction. Infusion reactions, anaphylaxis, anaphylactoid reactions are more common with iron dextran. So typically patients won't get that gram. They may get more like 500 grams or even 500 milligrams or 100 milligrams at a time for doses, just depending on the patient, depending if they're on dialysis or not on dialysis.